Hey guys, welcome to good afternoon. Good afternoon, everybody, and welcome to today's session. Today, we are here to discuss a small session on your INI-CET exam, just a revision kind of stuff for your upcoming INI-CET. So, stay with me. I have a couple of clinical based MCQ scenarios which I'm going to discuss with you. So, yeah, let's begin with this. Before this, let me just check if everything is all right, if I'm live and everything is going on great. Just let me see that. Right. Okay, that's great. I think I'm audible and visible to you, all of you guys. And let's begin with today's session. So, guys, welcome to the last leap for your INI-CET exam. Your INI-CET exam is just around the corner. So, I welcome all of you for the small revision for that. Let's begin with the first question of the day. The first question which I have for you guys is let's say there is a patient in whom you performed a USG. So, okay, this is a USG which is being performed in the right upper quadrant. So, it is kind of a image or cross-sectional image of liver which you're basically seeing. So what I'm trying to ask you, I have kind of an image with this particular kind of thing. So you have labeled this particular circle as A. Okay, so this is A, this is B, this is C. Okay, and I told you that this is something which is a cross section of the liver. So what I'm trying to ask you is that what does this B stands for? Okay, what does this B stands for? Can you please let me know, guys? What does this B stands for? Is it like does it denote the portal vein? Does it denote your common hepatic artery, a right hepatic artery, or the bile duct? So what is denoted by the symbol B over here, guys? Now, if you answer that the answer, like if you say that the answer to this particular question is B, that is a common hepatic artery, you're absolutely correct. Now, what you need to understand over here is that um, you must have heard of a Mickey Mouse appearance, which you basically get on the USG. When you perform a USG in the liver, you get something which is referred to as a Mickey Mouse appearance. Okay, so you get a Mickey Mouse appearance. Now, what you need to understand over here, the lower part is basically formed by your, this is basically formed by your portal vein. Just above it to the right, what do we have? We have your bile duct. So this is what is your bile duct. And to the right, what we have is a common hepatic, or to the left, what we have is a common hepatic artery. So please remember this, because this is a kind of a relationship which you need to remember. This is an anatomical relationship between the structures of a portal triad. It is very, very important. So I hope you remember. In the question, they had asked you that what does this B denote? And B was pointing towards your common hepatic artery. Okay, I hope you got this. This is a very, very simple question which we had. Another important thing which I just want to cover over here, when you basically perform an ERCP, okay, when you perform an ERCP, where do you go in for a sphincterotomy? So I am sure that you guys know that we have to perform a sphincterotomy. What I'm trying to ask you is that this sphincterotomy performed at which position? So if at all I kind of ask you, at which particular position do you perform the sphincterotomy? Answer would be at 11 o'clock and 1 o'clock position. Okay, at 11 o'clock and the 1 o'clock position, you basically perform a sphincterotomy. Why so? Why so? What you need to understand over here, we have this kind of a bile duct at the 3 o'clock and the 9 o'clock position. At the 3 o'clock and the 9 o'clock position, what do we have? We have the arterial supply. So we have the arteries which are basically supplying the bile duct. And we already saw that at the 6 o'clock position, what did we have? We had a portal vein. Okay, so I hope you get the mechanics of this, because at the 3 o'clock and the 9 o'clock position, you have your artery which is supplying the bile duct. Below you have your portal vein, and that is the reason if at all you want to perform a sphincterotomy, you prefer to do it at 11 o'clock or 1 o'clock position. Okay, I hope it makes sense to you guys. This is another important point which you definitely need to remember. Okay, I hope I'm clear. Let's move on with the next clinical scenario. So here you have a 60-year-old kind of female who presented to you with a history of a recurrent abdominal pain. On imaging, basically you saw that there are multiple small cystic lesions which are giving an appearance of a bunch of grapes. Okay, so bunch of grape appearance in the head of the pancreas. So I just highlight this particular part. What you're basically seeing that there is a cystic lesion. A 60-year-old female basically came with a kind of abdominal pain and all. Imaging showed a cystic lesion of the pancreas, and in that, what you saw? You saw that there is a bunch of grapes in the head of the pancreas. Okay, what did you see? You saw that there is a bunch of grape appearance in the head of the pancreas, with a grossly dilated main pancreatic duct and all. Now, okay, so this is again important with a grossly dilated main pancreatic duct. You performed an ERCP. On an ERCP, you found an image like this. So I hope you are able to see where it's going. And what I'm trying to ask you, what is the diagnosis of this particular patient? So what do you think, guys? What is the diagnosis of this particular patient? Is this particular patient suffering from serous cystic neoplasia, mucinous cystic neoplasia, IPMN, that is your intraductal papillary mucinous neoplasia, or a pancreatic pseudocyst? What do you think, guys? What is the answer over here? Now, if you're trying to tell that, you know what, the answer over here is IPMN. What is IPMN? IPMN is basically intraductal papillary mucinous neoplasia. So what is this? This is your intraductal papillary mucinous neoplasia. Now, what you need to understand over here, what are we dealing with? We are basically dealing with the cystic lesions of the pancreas. And this particular appearance, which you're basically having in this particular image, this is what is called as a characteristic fish mouth appearance. Okay, what is this? This is a fish mouth appearance. Okay, what is this? This is a characteristic fish mouth appearance over here. I hope you got this point, right? It's a characteristic fish mouth appearance which you have, which is giving you a diagnosis of an IPMN, intraductal papillary mucinous neoplasia. Right. Now, what I'll do, I'll just summarize the three important things for you. So we have three important cystic lesions. We have a serous cystic neoplasia, we have a mucinous cystic neoplasia, and we have a IPMN, intraductal papillary mucinous neoplasia. Okay, we have these three things. What you need to understand over here. Serous cystic neoplasia, this is more common in females as compared to males. Mucinous cystic neoplasia, this is all the way more common. Like the chances of, like, it is more common in the females, much more as compared to that of any other thing. So like this is something which is at least 10 times more common in the females as compared to that of the males. What about the IPMN? It is more or less equal in females and the males. Okay, it is more or less equal in the females and the males. Now coming to the important stuff. Now let's kind of see how do you distinguish between them. So what do you use to distinguish between these guys? So you use mucin staining, you use CEA, and you use amylase level. What you need to appreciate over here, that if at all CEA is elevated, okay, if at all the CEA is elevated, it is denoting that it is a malignant lesion. If at all amylase is elevated, what it indicates? It indicates that there is a connection with the main pancreatic duct. Okay, I hope where it is going over here. So if at all it is elevated, it is indirectly telling you that there is a connection with the main pancreatic duct. Now coming back to this, how do you distinguish? As the name suggests, it is serous cystic neoplasia. So what do you think? Will mucin be positive over here? Absolutely not. Mucin is absent in the serous cystic neoplasia. No brainer over here, absolutely no brainer. And it is like the next cystic lesion which we have is the mucinous cystic neoplasia. So obviously here the mucin would be present. I hope you got this point. And the final one which we have is the intraductal papillary mucinous neoplasia. Obviously here also the mucin would be present. Are you able to understand this point? Mucin absent, mucin present, mucin present. Now coming to the CEA. Coming to the CEA part. Now CEA, if at all it is elevated, it is indicating that, you know what, it is a malignant kind of a lesion. So in the serous cystic neoplasia, what about the CEA? CEA level is low. What about the mucinous cystic neoplasia? Here the CEA level is high. And what about the IPMN? Here also the CEA level is high. What about the amylase level? In the serous cystic neoplasia, the amylase level is low. In the mucinous cystic neoplasia, it is again low. And in the IPMN, it is high. So you really need to understand these guys, okay? You really need to understand this because they might give you that there is a cystic lesion. You went ahead, you aspirated some fluid out of it, and then it found that, you know, CEA was elevated and amylase was also elevated. What is the diagnosis? The diagnosis would be IPMN. If they give you that the CA is high and the amylase is low, then the diagnosis will point towards mucinous cystic neoplasia. And if at all they give you that CA and amylase both are low, then it will kind of point towards your serous cystic neoplasia. Okay, I hope you get this point. Now let me just finally explain you why this is a fish mouth appearance. So what you did was you did an ERCP and you just cannulated the ampulla. So as soon as you cannulate the ampulla, I hope you're able to appreciate that such a large amount of the copious mucinous secretion which was present in the main pancreatic duct, it just came out. And it gave an appearance of a fish mouth appearance, as if the kind of the fish is opening its mouth or something. Okay, so that is why it is called as a characteristic fish mouth appearance on the ERCP, and it is a very, very characteristic thing of IPMN, that is intraductal papillary mucinous neoplasia. Okay, I hope you understand this particular point, guys. Everybody got this point? So it's a big, big table, but even if you remember these 3 points, you'll be okay. You'll be able to kind of solve around 90% of the MCQs, which are asked from serous cystic, mucinous cystic, and the IPMN part. I hope we are all on the same page. With this, let's move on to the next question. So the next question which I have for you guys, there is a patient with a chronic pancreatitis. Patient is unable to kind of eat because of the persistent postprandial pain. So here he is not able to eat because of the persistent postprandial pain. Okay, that's fine. Now CT is kind of performed and which has been shown to you. What is the recommended treatment for this particular patient? So yeah, can you please tell me, guys, what is the recommended kind of a treatment for this particular patient? Okay, so let's kind of evaluate the CT scan first. So here, what do you have? You have this anechoic mass. Okay, so what is this? This is an anechoic lesion. What do you understand by anechoic? Anechoic means black. So it is an anechoic cystic lesion which is basically present around the pancreas. I hope you are able to appreciate it. So most probably this particular question is trying to tell you that we are dealing with the patient of a pseudocyst of pancreas. Okay, that is what this particular question is trying to tell you. Coming back to the options, what will you do over here? Nothing by mouth and the total parenteral nutrition for 4 to 6 weeks, percutaneous catheter drainage, endoscopic drainage, or an open internal drainage. Okay, so what do you think, guys? What should be done in this particular patient? Okay, so first of all, what you need to understand, the basic concept which you have, like if at all, let's say there is a pseudocyst of pancreas, pseudocyst, and if I ask you what is the treatment, most probably you will say that, you know what, let's keep it conservative. But if at all, the lesion is more than 6 centimeters in size, or it is kind of more than 6 weeks old, or like the wall thickness is more than 6 millimeters, then you might consider the drainage. That's all fine. But what you need to appreciate is symptoms. Symptoms are the main or the key feature to be considered. If at all the patient is symptomatic, you definitely have to go in for an intervention. You cannot just sit around. If at all the patient is symptomatic, you definitely have to go in for some or the other intervention. So I hope you understand this particular point. Here, the patient is having a persistent postprandial pain, and definitely you have to go in for the treatment. So none of the options have been given as a conservative management, but even if the conservative management would have been the option, you wouldn't have gone for it. Okay, please understand, it's all fine, like more than 6 centimeters, more than 6 weeks, all that is fine. But the main or the key feature to be considered is the symptoms. If at all the patient is symptomatic, you definitely have to go in for the management. And here, we all know that we have to go in for a open internal drainage. We cannot go in for an external drainage until and unless the patient is having an infected pseudocyst. Here, in this particular question, there is nothing to point towards that this is an infected pseudocyst, and definitely we have to go in for an operative internal drainage. We have to most probably go in for a cystogastrostomy or a cystogegenostomy or something like that. I hope you understood this particular point. This is how you manage a patient of a pseudocyst of pancreas. The whole point what I'm trying to make is symptoms are the primary feature. Even if, let's say, the kind of the duration of that particular cyst is less than 6 weeks, but the patient is symptomatic, still we have to go in for the treatment. This is a primary thing which you need to understand over here. Moving on with the next question. So there is a 46-year-old kind of male undergoes a distal gastrectomy and the small tumor of the gastric antrum, and then the biopsy proved to be adenocarcinoma. That's fine. Whenever you kind of go ahead and operate on any particular tumor, you remove the gross specimen, and at the same time you have a margin of resection. If I ask you what is the margin of resection which we have for the stomach, so what you need to understand, the answer is 6 centimeters. Like the Sabiston basically mentions that the 6 centimeters, but yeah, you can take 5 centimeters as well. So 5 to 6 centimeters is the margin of resection which you basically have whenever you are operating on any gastric carcinoma, right? Now, after this particular kind of patient was operated, what happened? The histopathological report. So whatever the specimen we take out, we send it for the histopathological report, and then we wait for a couple of things to confirm the diagnosis. And what we are mainly concerned about is the margin. So always we are concerned about, is the margin involved or is the margin free? what we would like, we would like that the margin is free of the cancer. But in this particular patient, what happened, the pathological kind of report reveals that the microscopic evidence of the tumor at the margin. In other words, in this particular scenario, what is happening, the margin is positive for the tumor. Okay, so the margin is involved with the tumor. Which of the following is the most accurately describe this particular resection? So is it like your D1 resection, D2, R0, or the R1 resection? It's a pretty simple question. The answer over here is D, that is, it is a R1 resection. Okay, now before I go into this R0, R1, and R2 resection, let me just cover this D1, D2, and the D3 resection in a short while. So what you need to understand is, we have the stomach, and around the stomach we have various stations of the lymph nodes. Okay, so we have 16 stations of the lymph node around the stomach. Okay, so around the stomach, what do we have? We have 16 station of lymph node. Do you understand this point? So we have 16 stations of lymph node around the stomach. Now, depending on how many lymph node stations are we removing, please mark my word, it is not the number of lymph nodes, it is the number of stations which we are removing. Based on that, we can kind of categorize it into D1, D2, and the D3 gastrectomy. So in the D1 gastrectomy, what are the number of stations which we are removing? We're removing the stations from 1 to 6. Okay, we are removing the lymph node stations from 1 to 6. What about the D2 gastrectomy? We are removing the lymph node stations from 1 to 11. 1 to 11. And the D3, we are removing it from 1 to 16. Do you get this particular point? So it depends on number of lymph node stations which we are removing. In D1 gastrectomy, we are removing the lymph node stations from 1 to 6. In D2, we are removing from 1 to 11. And the D3, we are removing from 1 to 16. Now, this is whole different concept altogether. What we are concerned about in this particular question is R0, R1, and the R2 resection. Now, it's very simple. If at all you take out the specimen and grossly you're removing all the tumor, and then the histopathological report comes back, and even in that, you're not having any involved tumor. So like the margin is not involved with the tumor. If at all the margin is negative, and at the same time your gross resection is kind of complete, this is what is called as a R0 resection. Are you able to understand this point? So, macroscopic resection is complete. At the same time, microscopically it is not involved. So it is a R0 resection. If at all the kind of my macroscopic resection is complete, like grossly you're not leaving any tumor behind, but when the histopathological report came back, it had some kind of a tumor involved in the margin. It is what is called as a R1 resection. So as was in this particular scenario, you removed all the tumor, you sent the sample for the histopathological examination, it came out to be positive at the margin. That is what is meant by a R1 resection. And if at all, let's say there is some massive retroperitoneal carcinoma which is encasing aorta 360 degrees, so you go in for a debulking surgery. You basically go in for you just try to remove as much as the tumor which you can. Are you able to understand this point? Macroscopically, you're well aware that you're leaving the tumor behind, but just because it is kind of encircling such a vital structure, you cannot remove it. Are you able to understand this point? In such a scenario, if at all you have something like that, that is what is called as a R2 resection. So here, macroscopically, you're leaving the tumor behind, and definitely when you send it for the histopathological examination, the margin will be positive for the tumor. Right? I hope it makes sense. Nothing great about it, but that is just a concept of a R0, R1, and the R2 resection. With this, I move on to the last question of the day. So the last question which I have for all of you guys is, okay, so there is an 85-year-old woman, kind of has a severe abdominal pain and an abdominal distension. She's kind of tachycardic, oliguric, and acidotic. Okay, that's fine. Now, she underwent an abdominal radiograph, and abdominal radiograph is shown to you. I'll just show it to you guys. So in that radiograph, what you're basically seeing, you're seeing a pneumobilia with a mass. Okay, so there is a pneumobilia and then there is a mass as well. What is the best surgical management for this particular patient during like exploratory laparotomy? So obviously you went ahead and did an exploratory laparotomy. What I'm trying to ask you, what is the best line of management for this particular patient? So let me just show you the radiograph. So this is a radiograph and you have an arrow over here. This arrow is trying to show you the mass. Are you able to understand this point? So here you are able to see the mass. Okay, so there's a pneumobilia, that's fine, but at the same time there is this particular mass which is kind of present over here. I hope you're able to understand this point. So what is the diagnosis, guys? I hope all of us are on the same page. Here there is a patient who came to you with signs and symptoms of your intestinal obstruction. Along with the patient had your pneumobilia and there was an ectopic mass in the distal part of the ileum. I hope it rings the bell that we are talking about a gallstone ileus. Okay, what are we talking about? We are talking about the gallstone ileus. Now, let me just cover this up for you guys, a couple of points, important points regarding this. So let's say there is a gallbladder like this. We have a stone inside it. Okay, we have a stone inside it. Now, what do we have? We have an intestine which is kind of traveling just near this particular gallbladder. Now, what happens over a period of time, chronically, what is going to happen? What is going to happen? This gallstone can erode through the wall of the gallbladder. It can erode through the wall of the intestine, and then it can actually enter into the intestine. Okay, it can actually enter into the intestine, and then it can travel distally. It can travel distally, and it can lead to the obstruction. The most important point is, where does it lead to an obstruction? So what is the point where the stone might go and kind of obstruct? So it is not at the ileocecal junction. One of the common misconceptions is it goes and it obstructs the ileocecal junction. That's not true. It is trying to go, and it is going and it is obstructing at just proximal to the ileocecal junction. Okay, it is just proximal to ileocecal junction. Okay, I hope you get this point. So the narrowest part of the small intestine is just proximal to the ileocecal junction, and this stone is kind of going and obstructing over there. So what you're basically seeing over here, this mass is nothing. This is just an ectopic gallstone which you're basically seeing. At the same time, what is going to happen? There is an air which is present inside the intestine. This air may go inside the biliary tree, and that is the reason why you get pneumobilia. Okay, this is the reason why you're getting pneumobilia. So on the clinical examination, you're getting the signs and symptoms of intestinal obstruction. You are getting ectopic gallstone, which is not present in the gallbladder, which is present in the distal part of the ileum. And at the same time, you're getting a pneumobilia. This basically constitutes your something which is called as Wriggler's triad. Okay, this is very important. I'm sure you guys know about this, but this is what is constituting the Wriggler's triad. What are the three things? So we have an ectopic gallstone. We have a patient with signs and symptoms of small bowel obstruction. And then we have pneumobilia. Okay, so all these three things, they constitute something which is called the Wriggler's triad. Now, all of this is fine. This is all the background. What I'm trying to ask you, what is the management for this particular patient? So the whole point is, do we just remove the stone, or do we have to correct the fistula also at the same time? Now, you might think that, you know what, let's correct the fistula as well, but it will take time, right? And this is a kind of 85-year-old kind of female who is already having oliguria and the acidosis and the tachycardia and all those stuff. It basically kind of shouts to you that, you know what, this patient is not completely hemodynamically stable, and you should kind of get done with the surgery as soon as possible. And that is the reason why what you basically do over here, you do not go in for a kind of your repair of the fistula. You just go in for, okay, so I'm really sorry, it's not a cholecystectomy. Okay, you just go in for an enterotomy and the removal of the mass. Okay, you do not perform a cholecystectomy at the same go. You will call the patient after, let's say, a couple of months, and then you might perform a cholecystectomy. But at this moment of time, you just kind of remove the stone, and that's it. You do not touch the fistula. You do not remove the gallbladder. And the simple reason for this, because the patient is comorbid, the patient is kind of elderly, and the patient is not in a very, very good physiological state at this moment to prolong the surgery. That is why we get done with the surgery as soon as possible. And yeah, that's a wrap. Okay, I hope you are able to understand this point. This is all what you need to understand. That's all, guys. That's all. Thank you so much for joining with me today. It was indeed a pleasure interacting with all of you guys. Thank you so much. I hope you gained something out of it. So, guys, as you know that I basically am an educator of surgery on an academic platform, it is an absolute pleasure to kind of connect with you, and I would love to connect with you on all the other things. So first thing, guys, please download the app so that you will be able to browse through all the important special classes which we keep on conducting on our platform. At the same time, if at all you're interested in taking a subscription of kind of an academy along with the prep ladder, there is something which is called as an iconic subscription. You can avail that if at all you wish. At the same time, we are coming up with a nationwide free grand test that is called as a championship T20 test. If you wish, you can just attend it. I would advise you to attend it. It is basically on the November 15th morning, 10 a.m. You can attend it, and yeah, it will give you a ranking based on all India level, like many students are going to take part in it. At the same time, you can also browse through our plus courses. One of the plus courses which we have is this INI-CET 2020, a short, like a very, very short course. So in this, we are going to cover the last minute revisions, the important images, and the clinical based scenarios and all those stuff. So, yep. I hope you get this particular point, so you can just kind of have a look at it, all of these things. And if at all you kind of wish to join any of the plus courses, please consider using the promo code Surgery101. That's it, guys. Happy studying. I hope you enjoyed this particular session. If you have anything to ask, please do ask me. And yep, have a great day. Which read to your book for the GI surgery? Frankly, you don't need to read any special book for the GI surgery. Just focus on your 11 Billy and your MCQ book at this moment of time. If you are as an MBBS student, please do please do cover your 11 Billy. If at all you're a final year student, please definitely, please make sure that you read 11 Billy so that your kind of concepts are kind of cleared. I know it sounds very cheesy, but please do not compromise 11 Billy to read any suboptimal book just to clear the exams. I assure you, you're definitely kind of clear the exams. Just kind of put in the efforts and just try to get done with the 11 Billy. It is very important. If you are an intern, please do not read 11 Billy page by page because you have to prepare for all the 19 subjects, right? So you can rely on any kind of reliable notes or any guidebook or something. You can definitely do that. Don't try to read your assembly books or something like that at this point of time. Don't do any kind of heroic thing. Just stick to the protocol, just clear your concepts, and yeah, that would be kind of that. Okay, that's it, guys. Thank you so much for joining with me. It was indeed a pleasure interacting with you. Have a great time.